Okay, welcome back, clinical problem solvers. Here we go. Great to see everyone for a neurology VMR. So excited that Vale has a case. It's been a while since I've heard a case from Vale. There was a run of tuberculosis cases from Vale, making us always wonder TB or not TB. And just when we thought it wouldn't be, it would be. And just when we thought it would be, it wouldn't be. So always fun to have you presenting, Valeria. And do you want to introduce yourself and have the discussants introduce themselves, and then we'll go ahead and get started.
Okay, I guess I'll start then. Yes, hello everyone. My name is Gregory Atafo. I live in Accra in Ghana. Happy to be here to discuss this neurology case. It's always fun to learn a lot from you guys. So yeah, hope we come to a good diagnosis in good time.
Excellent. Welcome, Gregory. Happy to have you.
Hey everyone, I'm Umbish Dino and I'm an IMG from Lahore, Pakistan. And I'm really excited that I got invited for a co-discussion because I do have neurophobia and I hope that it ends today.
Oh, wow. That's a tall order to end it today. We will definitely reduce it if we end it today. That will be thrilling as well. And I think everyone knows Valeria, but do you want to introduce yourself, Vale?
Yeah, briefly, sorry, my connection just cut in the worst time. But yeah, I'm Vale. I'm talking from Lima, and I'm really excited to present this case to you all.
Fantastic. Okay. Any other orders of business, Maria, or can we go ahead and get started? We have a thumbs up from Maria, so all is well. Okay, Valeria, go ahead and tell us the chief concern.
Okay, the chief concern is visions.
Is?
Visions, or I guess, I don't know. Yeah, visions.
We might need a few more than one word for that one to understand what you mean. Yeah, I think I know. Yeah.
Visual hallucinations.
Visual hallucinations, that's what I thought. Okay, great. Gregory or Umbish, you want to discuss your initial thoughts on visual hallucinations?
Sure. Gregory, you want to go first?
Sure. Okay. Right. So that's quite a very vague, non-specific presenting complaint, but I guess we can work with it. So first of all, I would love to know the patient's age, gender, and when I hear visual hallucinations, first of all, I'm thinking, so if I start with the brain, then I'm thinking, could this be a space-occupying lesion in the brain? And how long has he or she had the visual hallucinations for? Is this an acute onset? Is it subacute? Is it chronic? Would also love to know more about if the patient has had any form of substance use over the period. That could also account for the visual hallucinations. And in addition to the visual hallucinations, I'm looking out for other symptoms. Again, based on the patient's age and demographics, if I'm thinking along the lines of Parkinson's disease or Lewy body dementia, then I'm looking for associated symptoms that would come with those diagnoses. So these are things I'm thinking of for now. And when we get more information, then we'll go with that.
Yeah, fantastic, Gregory. So thinking about what the context is here, make a lot of difference. Is this someone who may have some recent intoxications to explain this? Is this someone who's much older who may have delirium as a result of some systemic insult, or they may have a primary neurologic reason for having visual hallucinations, such as dementia? So a lot is going to be a lot is going to come out in the history, and you gave us some important questions that we're all eager to know, that the age and some of the other contextual features for this patient. Any other things that were on your mind, Umbish, when you hear visual hallucinations?
Yeah, I absolutely agree with Gregory and all the diagnoses that he brought up, Lewy body dementia, and just finding out the patient's age, looking for small clues in the history. Sometimes substance abuse could be the cause of a hallucinogenic picture. And then I'm also wondering if the hallucinations are isolated visual, perceptual disturbances, or are they associated with any neurological abnormalities? And again, as we delve deeper into the case, we'll find more information to kind of correlate and form a picture. But for now, I have the same questions, and I'm wondering whether this is a monoocular problem or is it a binocular problem, and any associated findings.
Yeah, fantastic thoughts. So some people maybe looked surprised to hear visual hallucinations in a neurology morning report, right? Because we often think about visual hallucinations associated, for example, with psychiatric disease. And of course, the brain and the mind are the same organ. And so the more we learn about neurology and psychiatry, the more those barriers between those disciplines fall down. So many of you did something that I've started calling, when I'm not sure exactly how to approach a particular chief concern, what I call round to the nearest. So you might have thought, oh, I don't maybe have a framework for this. I know they happen in certain diseases, but I'm not sure I have a differential diagnosis. But maybe what you were slightly doing intuitively is saying, well, this is some type of altered mental status. I know how to work with that schema. I call that round to the nearest thing that you do recognize how to work with, and much of this will overlap. So this is something visual, right? So you mentioned, is it monocular or binocular? That's sort of an approach we use for diplopia or visual field deficits. But that could actually be relevant here if the patient is having hallucinations that they really are only in one eye. There could be some type of ocular problem. And there's something called release hallucinations. These are also common in older individuals with visual loss, but in any patient with visual loss, you can have what's called a release hallucination, also called Charles-Bonnet syndrome, where the absence of visual input from severe ocular disease or from severe disease in the visual pathways in the brain leaves sort of a gap for vision to fill in. We all know we have a blind spot, right? You've probably done these things where you look at a dot on a page and you move something and see it disappear in your peripheral vision, or before the screens in the car showed you what was behind you, that you were told to always look over your shoulder before you change lanes because we have that blind spot, but the visual system fills it in. So when you have more blind spots, the visual system can hallucinate things that are not there. So again, maybe we wouldn't normally think monocular, binocular for visual hallucinations, but that idea of rounding to the nearest problem we do know how to work with is helpful. Then you thought, well, what if these are just maybe part of a larger context of altered mental status? As you said, then we have sort of a framework for that. Is that a systemic condition affecting the brain? Is that a psychiatric condition causing this particular type of altered mental status, meaning seeing things that aren't there? Or is this a neurologic condition, such as a neurodegenerative condition? Bisha made the really interesting point about auditory hallucinations. We actually do see visual hallucinations not a fair amount, sometimes in neurologic consultation. Some of that is part of delirium in the hospital in patients with a systemic illness who are older or disoriented or have an underlying neurologic disease in conjunction with a systemic insult. Or we see the visual hallucinations of in Lewy body disease, not uncommonly, but it's pretty uncommon, and I would actually say extremely rare. I'd go as far as to say extremely rare to see auditory hallucinations in neurologic disease. I don't know if this is just an observation or something that other people have observed or is written anywhere, but auditory hallucinations, these command hallucinations, I think are very characteristic of psychiatric disease, whereas visual hallucinations may be a little more general to different types of conditions, including just the loss of vision. The other thing we might be interested in the history is what the patient is actually seeing. In Lewy body dementia, do either of you know, Gregory or Umbish, by chance, what the hallucinations are usually described as?
Not sure how they're described as. All I know is that the hallucinations oftentimes precede other symptoms. Not sure the kind of hallucinations.
Yeah,
but I'm assuming they are visual, right?
Yeah, they're usually visual, and they're actually usually non-disturbing, and they're usually little people or little animals for some reason, very characteristic of Lewy body disease. They'll say, I looked outside and I saw a lot of these little people. I knew they weren't real. Or I saw a lot of little animals. It's not like the visual hallucinations of alcohol withdrawal where there's bugs crawling everywhere and very disturbing hallucinations. Very moving. I recommend anyone interested in neurology, or if you're not, this will make you interested in neurology. Very moving podcast in the last 2 or 3 years of a neurologist who's a specialist in Lewy body dementia, who has developed Lewy body dementia, describing some of his experiences. And one he describes is called the presence, which he said he'd observed in patients and had himself, and it was a sort of hallucination that somebody is near you, even when they're not. And he described this very beautifully as actually being a sort of almost comforting hallucination, the hallucination that kind of there's just someone kind of walking with you. Anyway, so that could be helpful. There's another type of visual hallucination maybe people have not heard of, just fun to put on the table. called peduncular hallucinosis. And this is hallucinations actually from midbrain lesions. This is pretty uncommon. I've seen once or twice. And the hallucinations are what one of my colleagues called almost like a sort of virtual reality, in this augmented reality, in the sense that the patient's hallucinations kind of coordinate with what they're actually seeing in a sort of an embellishment. So we had a patient tell us that overnight in the hospital, they were taken through this magical tunnel and there were synchronized swimmers going by and they went into a spaceship and all this. And you realize if you actually went into a hospital tunnel at night and saw the coordinated actions of all the people working in the tunnels going by, and then, oh, the spaceship was the MRI and the blast off was the noise, everything was based on in some way on reality, but it has sort of this kind of fantasy overlay, and that's called peduncular hallucinosis from a midbrain lesion. Okay, so what's on the table here? Primary psychiatric illness, systemic condition causing maybe delirium, Lewy body dementia we've discussed, maybe a midbrain lesion that's very uncommon, sort of gourmet neurology trivia for fun. And then some type of neurology psychiatry overlap if this turns out to be a young patient with new hallucinations. That could be primary psychiatric disease, but could be, for example, something like NMDA encephalitis or infectious encephalitis, some condition affecting sort of neuropsychiatric function. Okay, not something maybe I have a very specific schema for, but I think together, the three of us, we came up with some ideas that will help guide what we take from the history and from the exam. Okay, Valeria, tell us what you found on the history.
Brilliant, as always. Okay, so for the HPI, I have, this is a 60-year-old male that went to the ED referring 2 weeks of episodes that started with an oscillating red light that grew bigger and bigger, and then the appearance of angry, non-familiar faces that he interpreted as accusing him of something, but he identified that they were not really there, that they were not real. And they predominated in his left visual field, and they occurred 4 to up to 10 times per hour. They awoke him at night as well, and the episodes lasted less than a minute. The episodes were preceded by a right parietal and occipital headache of moderate intensity. And on review of systems, he also referred blurry vision for the past year.
Okay, excellent. That's a lot to work with. Umbish, do you want to go first this time? I think Gregory spoke first this time.
Yes, I can go first this time. So we do have a lot of new information on this patient. First of all, the age. The patient is 60 years old, right around the time where, things like Parkinson and, other pathologies like delirium and, basically neurodegeneration sort of starts to, we could keep it under consideration. And then the other thing that is noteworthy here is that the symptoms were more localized towards the left. They were associated with an occipital headache. And that makes me wonder, is there a space occupying lesion there that could be causing these symptoms? And then we've already talked about the kind of hallucinations, and looks like this person was aware that these people that he was seeing were not really there. So the course of symptoms, the association so far is kind of making me think of, migraine wouldn't be associated with this severe form of a visual hallucination. So I'm not going to, think of migraine really, but a migraine secondary to some underlying pathology could be it. And then it looks like all of these symptoms are associated with a particular underlying pathology. And on the top of my list, I'm thinking of a space occupying lesion, possibly. And then again, other neurodegenerative disorders. That's where I'm at.
Okay, brilliant, Umbish. There was a lot of fantastic things you said there. With you. One very important feature here is that these are happening in a focal way on one side. And whenever we see something on one side of the body, whether that's facial weakness or asymmetric reflexes or visual field deficit, we're looking for a focal lesion here. So excellent that you picked up that there's something going on the left here, and that might make you worry about something in the right side of the brain. Another interesting thing you brought up, I think we were all visual, we took maybe literally if we said sort of abnormal visual phenomena, would have all, so good for you, Umbish, to mention that. And that first one, the kind of flashing lights, that sounds kind of migrainous, but you made the important point that this patient is in their 60s. You can get new migraines at any age. But one, the visual phenomenology here is a little atypical for migraine. And two, you made the important point, migraine is a syndrome, it's a phenomenon, and you can get secondary migraine. Many people all over the world have just migraine. I don't know the exact percentage, but it's a high percentage. It's a very common condition that people have migraine headache. But the same symptomatology of migraine can have an underlying structural cause that's provoking the brain to have what's thought to be something called cortical spreading depression, which is some type of electrical activity which gives rise to the symptomatology of migraine. All excellent thoughts. Let me take this a little further with you, Umbish. What could be another way a structural lesion in the brain could produce visual phenomena aside from migraine? Any ideas?
I think if somebody is close to the optic nerve, that could also lead to visual disturbances. And then pressure symptoms.
Okay.
Due to a mass pressure and then pressure effect. I'm not sure if I understood your question correctly.
Yeah, it was a little bit guess what I'm thinking. I apologize. I'm trying to not give what I'm thinking away, but talk with you to try to think about something else here. So yeah, you're right. Obviously a mass with effects on optic nerve or something going on in the eye itself could maybe cause probably more likely more primitive visual phenomena, flashing floaters kind of things. These are pretty well formed. Let's round to the nearest, a structural lesion causing minute-long episodes of something here. It happens to be visual, but what else could you do with that? I know it's still a little guess what I'm thinking. Gregory Umbish, how could a structural lesion cause what seemed to be focal episodic phenomena, in this case visual, but
would that likely be around the occipital lobe, the visual cortex?
yeah. And so here we're seeing, again, let's round to the nearest, probably not fair. Well, sort of, yeah. Episodic, we're seeing something that's episodic, right? 4 to 10 times per hour. There are episodes of some focal phenomenon that come and go with no clear trigger. And they seem to be provoked here by a structural lesion. Can anyone guess what I'm thinking? I'm obviously not asking the question very well. What if, yeah, go ahead. Did you have a thought, Gregory, or?
Yeah, I was thinking a parietal lobe lesion. If a patient, for example, has this thing where they fail to recognize familiar faces, right? That could the non, I think is it the dominant, the dominant parietal hemisphere, I think. So that could also account for something like that.
Yeah, good thought. You're wondering about prosopagnosia, which I think is usually due to medial temporal, the face area, if I'm not mistaken, there somewhere along the so-called what pathway. What if this structural lesion, instead of what seems to be in an area to provoke visual symptoms, was near the motor cortex, and this patient was saying 4 to 10 times a day, my arm feels funny for 1 minute, and then it gets better. Maybe shakes and jerks a little bit. Then what would you be thinking? My thought exercise is maybe I'm not doing it well here. Go ahead, yeah.
Yeah, then it makes me think of a stroke, and then it is usually associated with personality changes as well. So
yeah, I think I'm trying to key in on the episodic piece here, which was an interesting piece, and trying to trying to think about seizure here. So very uncommon for seizure to cause visual phenomena, but as soon as I started hearing there's a sort of kind of very primitive geometric figure as the primary visual hallucination, this flashing red light, you thought of migraine Umbish, which was a great idea, structural lesion causing migraine. But this is happening several times an hour and seems to be associated with headache. So we thought of a structural lesion, and another mechanism by which a structural lesion could cause episodic symptoms is by causing seizures, excuse me, focal seizures. And you can get seizures from any part of the brain. We think of the seizures arising from or spreading to motor regions, causing shaking, twitching, jerking of the contralateral limb if they're focal seizures, or if they're generalized both sides of the body. But seizures can do anything. One thing you'll learn if you're a neurology resident, often the hard way. I learned, even not as a neurology resident, last week, after 10 years in practice after residency, that you can always get surprised by what seizures can do. There's ictal spitting and post-ictal nose wiping and ictal laughing and all sorts of things where you'd think that can't be a seizure, and guess what? It can be a seizure. So you can get occipital lobe seizures. And usually, for whatever reason, the phenomenology is some sort of primitive geometric shape, like a bright square, a bright circle. One of my colleagues, Dr. Sashank Prasad, who some of you know from Neurotrivia, who's at Penn, said he had a patient who described, you know, when you're, if you have an Apple computer and it freezes, that rainbow spinning thing. One patient described that, and that he had the EEG correlate coming from the contralateral occipital lobe. So I'm wondering now if those light growing bigger, episodic could be actually a seizure type phenomenon generated from the occipital lobe from some type of structural lesion. The sort of non-familiar angry face as a seizure, usually these are not complex figures like that. That sounds a little more like a hallucination, but the fact that it's on one side, recurs with this periodicity, and is associated with this sort of headache on the contralateral side makes me worried there's a structural lesion there that's provoking occipital seizures. What the structural lesion is, this has just been going on for a short period, so hard to say at this time. Could this still be neurodegenerative disease? As we said, a patient's only 60, not very old. May sound old to some of you, but as some of us get older, the range of what sounds old is changes. So 60 is not that old to think of developing neurodegenerative disease. While we're paused on that topic, or to pause on that topic for a moment, there are neurodegenerative conditions with primary visual phenomena as the presentation. We mentioned Lewy body and dementia with hallucinations, but it's actually a variant of Alzheimer's disease called, I think it's called Benson's disease is the eponym, or visual variant Alzheimer's disease, or posterior cortical atrophy, where instead of in the medial temporal lobes and parietal regions causing early loss of episodic memory and spatial reasoning with getting lost, et cetera, as we see in Alzheimer's disease, these patients develop difficulty with visual cognition and can have problems with visual awareness or difficulty with visual tasks. You can see that actually in Lewy body disease as well. Some of these patients will end up getting cataract surgery or have other procedures on their eyes until someone figures out this is actually not an eye thing, it's difficulty with higher order visual processing. That can occur at the beginning of Lewy body disease, that visual variant, also called posterior cortical atrophy, visual variant Alzheimer's disease. There's a variant of Creutzfeldt-Jakob present with visual phenomena that is called, I think it's the variant, and that may be. Okay, that being said, a headache and sort of the relatively fast onset and progression here makes us think more of something structural. What type of structural focal lesion in the brain could cause symptoms emerging, evolving over weeks? Any thoughts on that, Gregory and Bish? We are probably localized here, as Bish told us, we have left-sided visual things. A right-sided headache looks like we're sort of right and posterior. So now the time course, it's been going on for a few weeks. Any thoughts on what type of process could progress over weeks in the brain?
So this is relatively fast. It can be a malignancy, but a very how do I put this? A very rapid growing one. So like glioblastoma, for example. It could also be an infective process, especially because of the subacute nature. So those are two things I'm thinking about at this point.
Yeah, both excellent thoughts. Yeah, it's interesting. You mentioned a mass. It sounds a little bit fast, but for some reason, often when masses grow in the brain, they can get quite large before they actually cause any symptoms. Actually, sort of a characteristic feature of one of the common primary brain tumors, glioblastoma, fortunately not common overall, probably about 1 in 100,000, but amongst the cell type of common brain tumors after meningioma, which is dura, not brain, the glioblastoma. One characteristic my mentor, Marty Samuels, often pointed out in these cases is the clinical deficits are often relatively mild in proportion to how big the mass is. You might see patients with a large glioblastoma taking up what looks to be most of a lobe, and all they have on exam is a pronator drift. And they presented with seizure, and that's how you figure it out. And if you had a stroke or a hemorrhage of similar size in that region, the patient would have a huge deficit. So something about how this tumor grows and kind of makes its way along white matter pathways since it's the glial tumor. can sometimes cause the patient to present at an advanced state of the tumor without much to show for it on exam. And often they do present first with seizure, and then you might notice these subtle focal deficits. That's certainly a possibility. Other possibilities, much more common than glioblastoma, would be metastases from a systemic cancer. And then you mentioned infection. Valeria has given us many infections and shown us many ways that tuberculosis can come about, from Pott's disease to, I think there was a meningitis case, but this patient had a tuberculoma in the occipital region on the right, provoking these seizures. So it really could be anything. So maybe we'll get some clues in the past medical history, social, etc., things to think about. Otherwise, probably we would, to get further, need to see some brain imaging to understand going on. Okay, so excellent discussion, and Beach and Gregory. Valeria, anything out in the west corner here?
Yes, so for this aliquot, the patient has a medical history of diabetes diagnosed 2 years ago and hypertension diagnosed 5 years ago. In his medication, he takes insulin, NPH, losartan, amlodipine, and hydrochlorothiazide. The doses I don't remember exactly, but he did refer that his insulin access was limited. And health-related behaviors, he has one sexual partner with intermittent use of condoms, and he drinks 4 times a week, often until losing consciousness. I can also give you the physical exam if you want that.
All right, let me just hear the last part about the drinking. I missed the last thing you said.
Oh, sorry. He drinks 4 times a week, often until losing consciousness.
Often until losing consciousness. Got it. Okay. Gregory, Umbish, anything? Does this help us? Help you?
Okay,
Yeah,
so let me go first. Okay, Umbish,
Okay,
go on.
go. Okay, I'm sorry, my connection is a little bad, so the voices are breaking up a little for me. So I'm sorry if I'm interrupting anyone. Yeah, so the only pertinent thing so far, actually 2 of them. One is hypertension, which could lead to an ischemic stroke, and then that makes me think of those pathologies. The other thing that is of significance here is the alcohol consumption. And then I was just wondering, alcohol withdrawal can also present with auditory or tactile or other forms of hallucinations. But 4 times a week, not sure the quantity, and would like to know more details, but that's the only thing that I'm thinking of right now.
Yeah, fantastic. Yeah, I agree. Probably not too much to do with diabetes and hypertension. Just to put it out there, you can actually get focal seizures with hyperglycemia. Why that is not entirely clear. You think most toxic metabolic insults cause generalized seizures, but you can get focal seizures. And actually, we had a case on VMR many years ago. I think it was Gabby's case of hyperglycemic hemichorea, where you get chorea on one side of the body from hyperglycemia. Again, why should it be on one side? The hyperglycemia is going everywhere. Unclear, but probably not causing these very specific visual seizures, but just so people are aware of that. And then I agree, much more common cause of visual hallucinations than whatever Valeria has for us today would have been the patient has a very heavy use of alcohol and maybe ran out or stopped drinking and is having some hallucinations. But again, even alcohol use is common and withdrawal is common. Probably with this history, we would say, gee, they're focal. They've been going on for some time while the patient is still drinking. They have a headache with it. We're still going to think about these separately from what could also be occurring due to alcohol withdrawal. Maybe this patient is, due to alcohol, intermittent alcohol use, may be more prone to seizure, and now with the mass making their seizure activity greater when they're not intoxicated or off alcohol. But I agree, probably not helping us toward the etiology. Okay, before we hear the exam, Gregory or Umbish, anything in particular on the exam that you think will be helpful here? Or what are you looking for on the exam? Yeah.
Well, so right now we have a possibly localized lesion, at least to the right side. So when we do the neurological examination, we're looking out for, again, if it involves the motor cortex, we're looking out for either motor impairment or sensory impairment if it involves the parietal lobe as well. I'd also be interested in doing an eye examination, a full eye examination. So I want to do a fundoscopy. One other thing that crossed my mind when they mentioned the diabetes, again, that's a risk factor. considering the oscillating red light, I know of a couple of patients who've had red lights. I know of a couple of patients who've had who've had diabetes for a long time, can develop vitreous hemorrhage and retinal detachment, and for some of them they get the floaters and the flashes, the photopsia, right? So that could account for some of the oscillating red light, but it would not count for his visual hallucinations, but it's still a risk factor in that case. So yeah, a full fundoscope examination will be pretty helpful. For the rest of the general examination, right, yeah, I guess again to still see if he's able to recognize patterns. If he's able to say, we ask him to draw a clock, if he can draw the full face of a clock or is just on one side, that kind of points us to like a parietal lobe lesion as well. So those are some of the things I'll be looking out for in the examination.
Yeah, brilliant, excellent. So thanks for that discussion, and we shall have you discuss then the exam when we hear the findings. So yeah, I totally agree. We have a lot of hints of a right-sided parieto-occipital lesion here by the history the patient's giving us of seeing things in the left visual field. So we'd want to see if there are any signs of that on exam. Is there a left homonymous hemianopia or a quadrantanopia, something that would put us on the right side and help us understand if it's superior or inferior. We want to see if there's any focal motor deficits on that side to get a sense of the extent of this lesion. And then great point, if everything looks normal, which I think we would be surprised by, then the question is there something in the eye? But as you said, to have such sort of specific formed hallucinations from an ocular problem would be relatively unlikely. With retinal detachment, et cetera, you get more sort of flashing lights, photopsias, et cetera. Excellent. And then you brought up drawing a clock. If this patient has right parietal involvement, they may have accompanying left-sided neglect and may draw just half of the clock face. So there are a lot of things we can do at the bedside to try to get a sense of the extent of involvement here. I love the neurologic exam, as many of you know, in terms of localizing. Here, the patient has given us so much compelling history, and we know we're going to need neuroimaging to figure out the what here. So sometimes this is just getting a sense of whether our hypothesis on the history is correct, or whether we have any surprises here, or whether we have anything on the general exam or otherwise that might be a clue to what's going on in the brain. I think the exam will be interesting as we make more precise our localization of this lesion, but I think neuroimaging here to confirm that location and try to get a sense of the what is going to be essential. Okay, Valeria, what did you and your colleagues find here?
Okay, amazing. So for the physical exam, on his vitals, the blood pressure was 130/60, heart rate 60. Otherwise, other vitals were normal. Well, these are also normal, but for in terms of the past medical history. And the general examination was normal. On the neurological exam, he was alert and oriented. He had unstable gait during the episodes, and then the neuro exam was completely normal when he was on his baseline without the episodes. But during the episodes, we did see left gaze deviation with horizontal nystagmus and loss of vision on the right visual field after the appearance of the hallucinations.
Loss of vision in the right visual field, did you say?
Yes.
Okay. What do you think, Unbish?
So far, the nystagmus and the altered gait makes me think of a cerebellar lesion. And also, when I read that when the flocculonodular lobe is involved, that is oftentimes when you see nystagmus, if problem is in the cerebellum. And then the other thing is that it usually happens during the episode, you see this, and otherwise the patient is fine. I don't know what to make of it, but that's a very interesting finding that it only happens during. If it's a seizure, then we would believe that it would happen during that time only. So, and otherwise the patient is alert, oriented. It doesn't seem to be, the vitals are, seemingly normal. So the only two pertinent details here are the unstable gait, the associated nystagmus, and then also the visual field, loss of vision in the right visual field, which is also is happening during the episode, or is it there?
Sorry, what was the question? I didn't hear.
The question is the loss of the vision in the right visual field. Is it like there throughout the exam, or is it also a finding that that is seen during the episode?
It was only during the episodes, but on the ophthalmology examination, I don't know if you want that part yet. Yes, or for later.
Let's try to make some sense of this. So yeah, so when you hear nystagmus, you're right, Umbish, normally we think of something along the vestibular pathways, inner ear, cranial nerve 8, brainstem, cerebellum. But I think maybe we think about it a little differently this way with the gaze deviation, and presumably the gaze is deviated, but having some nystagmoid movements. But you're right, the general implication of that term. But I'm guessing here, Valeria, correct me if I'm wrong, the gaze was fixed to the left and then kind of beating in that direction. Is that right?
Yes.
Yeah.
Yes.
Yeah. So what does that sound more like to you, Umbish, if we move away from the sort of nystagmus? The usual implications are a little bit different because the gaze also has a forced deviation.
So there's two things. One is a defect in the frontal eye field, which also then would point, right? And then the other thing I'm thinking of is the internuclear ophthalmoplegia that is also associated with nystagmus. But that would be seen if you are particularly trying to look towards the affected side.
Yeah, excellent. Yeah, so nystagmus, we could spend hours and hours. Maybe someday someone will bring a case of nystagmus and we'll still be in hour 4, we'll still be on the chief concern because there's so much complexity there. You're right, even an INO can cause some nystagmus in the abducting eye, the abducting eye. It sort of like feels like it's trying to pull the other eye that's stuck, that's not adducting. But here, when you get gaze deviation that's conjugate, usually that suggests a problem, as you said, with the frontal eye field, or less commonly with the paramedian pontine reticular formation, which the eye field communicates with. Just quickly, since I know we're all eager to know what was on the neuroimaging here, just as the right side of the brain controls the left side of the body, sees the left visual field, feels left somatosensation, the right frontal eye field sends the eyes to the left. And just as the left hemisphere controls the right side of the body, sees the right visual field, makes sense that it would want to send the eyes to the right. So if you have seizure activity that spreads to the frontal eye field, in this case, the right frontal eye field, then the patient often turns their head, turns their eyes, and then starts shaking on that left side. And then after the spell, when the frontal eye field is in its refractory phase, then the eyes might be looking back towards the lesion, and the patient might have so-called Todd's paralysis, the postictal paralysis on that side. And that postictal paralysis, as it were, often described with, the shaking arm is weak after. You can get a postictal kind of refractory Todd's anything. If there's seizure activity in the occipital lobe, you can get a contralateral hemianopia. I saw a patient with seizure activity that spread to the parietal lobe and had a postictal neglect, and then it recovers. I'm a little confused here because the visual phenomena are on the left. The gaze deviation is to the left. We're all rooting for the right hemisphere to be where the problem is. But then after the episode, the loss of vision is in the right visual field. That wouldn't make sense with a right hemisphere lesion. So I'm not sure what to make of that. Yeah, I'm not sure what to make of that. There is, we say seizures can do anything, but they shouldn't probably cause ipsilateral visual field phenomena on this side. Or if the thing is coming from the left, the eyes would have deviated to the right during the event. And after the event, the eyes would roll back towards the left and the postictal stays, and then they would have right-sided visual deficit. But something's not squaring up here with left and right. History made it sound like a right-sided lesion. Left gaze deviation during the event would sound like a right-sided lesion. Right visual field would be a little confusing. But okay, I think we've confirmed for ourselves in any case, these are seizures, as the history suggested, and their origin is a little bit unclear, depending on whether that gaze deviation is during the event, meaning frontal eye field active, sending eyes away from the side of the lesion, or the gaze deviation is after the event, and we're seeing the eyes looking back toward the lesion as they would when the FPF frontal eye field is ablated as instrument. Okay, we need a picture because we know this is in the brain, but we have talked about neoplasm infection, and so the radiologic characteristics are going to help us here. And so I'm going to guess the patient got some basic labs. I'm not sure they'll be too telling. And then the question will be what type of neuroimaging you did and what we saw. But tell us, Valeria, if we're going down the wrong path.
Yes, perfect. So for the initial test, we did the CBC metabolic panel was normal. We did find a glucose on admission on 496, and he was started on insulin, and his monitoring showed spikes around 300 to 400 of glucose, especially on the evenings. He also had a hemoglobin A1C that was 20. At this point, we were thinking along the lines of what you just mentioned, of if this could be a seizure. So we started him on carbamazepine, and his insulin therapy was optimized, but he persisted with the spikes. The episodes improved in frequency, but we did find a correlation between the spikes of glucose and the frequency of the episodes, with the caveat that the patient was not very consistent with his reporting of symptoms. That you mentioned, the fact that he did say that he lost vision on part of the visual field, but he sometimes said he did. He sometimes, responded when we examined him, as it seemed that he really could see what we were doing. So it was a little tricky. And then we also did an EEG that showed attenuation of rhythm of the posterior area of the right hemisphere. Of the left hemisphere, sorry. And then we also, no, wait, let me check if it's the right or the left. I'm just really confused. Let me check the original file.
You become a neurologist, keeping right and left straight gets so confusing because you're used to looking at the patient whose left is always on your right. You're used to looking at neuroimaging where the right is always on the left. You're so used to reversing it that then in real life you start getting confused.
Yeah.
To make a left turn, should I actually be turning to the right?
No, but it was right. It was right for the reader that I have here.
Everything doesn't square. Let's pause for a second. First, to remark on that hemoglobin A1C. Has anyone ever seen an A1C 20? I think I saw one around 14 or 15 recently, but 20. I would think that would mean your blood sugar is consistently in like the 900s or something. Anyway, that is impressive. And you did note there in what you told us that the symptoms seem to correlate with spikes in the blood glucose. And we did mention that hyperglycemia can cause focal motor seizures or focal seizures. It's described as motor seizures. One of the authors on that paper, which I think is a pretty old paper, maybe 90s, is a professor I got to work with at Mass General named Nagagopal Vena, who's a master clinician who described this. I've never seen visual symptoms, but I guess the question I would pose to you is, okay, this patient is having focal seizures. These have been described with hyperglycemia, maybe this type of seizure. This seizure activity seems to be correlating with the hyperglycemia. Does this patient still need an image? Are we comfortable with saying, oh, these must be hyperglycemic focal right-sided occipital seizures? Are we happy with that, or would we want neuroimaging? What do you think?
I think we still should go ahead and have an imaging done, most certainly, because yes, as for the diabetes, it looks like it's causing some microvascular complications in this setting, whether it's within the eyes as a retinopathy or it's within the brain, that's going on. But still, as long as we've been able to localize a lesion to the right side or to the left side, depending on what it shows, we still need to have brain imaging done.
100%, yeah. If the brain imaging is totally normal, then maybe we say, well, this is a case reportable example of focal visual seizures, occipital seizures from hyperglycemia. But it may be that those spikes in glucose are lowering the seizure threshold, and the focality here is due to an underlying structural lesion. So I totally agree. We want to see if there's something there that is the nidus for seizure, and the glucose is just kind of the exacerbating factor. And it would be a diagnosis of exclusion to say these are very atypical hyperglycemic seizures, and we'd want to look under every stone before we conclude in that. Okay, Valeria, did your team do neuroimaging, and what did you find?
Yes, so for the brain CT initially, we were hoping for something, more remarkable because of the history of two weeks. But we only found a small hypodensity next to the posterior aspect of the left ventricle, and otherwise the radiologist said it was normal. The patient was seen by ophthalmology, and they reported findings compatible with diabetes retinopathy. And the patient was discharged after this because of the decrease of frequency of symptoms. He was discharged with anticonvulsant therapy and came back with an MRI that he did at another place, because we don't have MRI in my hospital. And the MRI did show hyperintensity. Let me I have it here. Yes, I have hyperintensity with diffusion restriction in the left occipital lobe. And I remember very well this this moment.
Okay. Yeah.
Yeah.
Yeah. Did you have more you wanted to say, or should we pause there before?
No, take it away.
Okay. Okay, Umbish, Gregory, what to make of all these things? How do they help or not help us?
Well, so first off, I wanted to find out, at the point where the patient was discharged, was it just on the anti-epileptic, or were his diabetic medications altered in any way? That's the insulin, and the insulin at least keeps some better control of his sugar. That's the first thing I wanted to clarify.
I just wanted to say that this is I just wanted to illustrate the diffusion restriction, but this is not the MRI of the patient. It's on the other side. Yes. No, this is an image from Radiopedia. But yes, I don't have the images of this patient. It happened a while ago. And yes, he was only on carbamazepine when he was discharged, and on insulin. That was the medication he was on for diabetes.
Okay, so you're giving us an example of diffusion restriction here, not in the same place, pattern, etc. of this patient. Okay. All right. So do we have a diagnosis here with this CT, MRI, ophthalmology report? Yeah, that's okay. Whoever is so diligently trying to fit the MRI there, if it's not the MRI of this patient, probably it will lead to more confusion of people who listen.
Yeah, with the left and right, it just, I think it's gonna confuse more people. Thank you, Kuchal.
It's though for trying. Yeah. Any thoughts, Umbish or Gregory? What do you have a final diagnosis?
Yeah.
Other test you would like?
I'm not sure what the diagnosis is going to be, but all I can see is that you guys did almost reach the diagnosis, which was diabetes related pathology. But then the hyperintensities are making me wonder, were these transient ischemic attacks or mini strokes secondary to the seizures that the patient was having, or was it something completely unrelated? That's what I'm wondering right now. But the hyperintensities do feel like there was some form of ischemic sort of damage going on in the brain, which is why you saw the findings.
Yeah. So yeah, this is tough. So the CT, it's interesting. There was one small hypodensity. We'd have to really look at it to get a sense of whether it looked kind of fresh, a sort of evolving hypodensity where it's sort of blurry, or whether it really looked chronic and punched out and not related. If there's a correlating MRI finding, that tells us probably it was a more recent phenomenon. And then the question is what it is. I'm still a little confused why the patient has a left-sided visual phenomena, left gaze deviation, and a left-sided lesion, although the right visual field might that and have and confusing, but the condition is on. We're going to have to find a way to square that to work with, and so we have to work with it. So when people hear diffusion restriction, they often associate that with stroke. It's a sequence used to look at stroke. But diffusion restriction has a differential diagnosis. What's happening in diffusion restriction, I don't totally understand the physics, but this MRI sequence is looking at the ability of water to diffuse through tissue. So where there is where it is more difficult for water to diffuse, you get diffusion restriction. So already on a normal diffusion-weighted imaging sequence, you'll see the cortex slightly brighter than the white matter because the cell bodies are there and it's harder to get water between them than between axons. What pathology causes diffusion restriction? Well, stroke, acute ischemic stroke, because there is cellular swelling and it's harder for water molecules to sneak between the cell bodies. seizure activity actually itself can cause diffusion restriction. Probably similarly, there's some cytotoxic edema. An abscess can have diffusion restriction. If you think of the pathology of abscess, there's lots of little cells in the pus there that are making it hard for water to diffuse. Primary CNS lymphoma in immunocompetent patients. For some reason, not in immunocompromised patients. It looks different radiologically, but in immunocompetent patients, think of the pathology, lots of little blue B cells there. Creutzfeldt-Jakob disease, the cortical ribbon is diffusion restricting. So here we have focal diffusion restriction on the left. Did this patient have a stroke 2 weeks ago in an area of the visual cortex that is now provoking these seizures, or is triggered to provoke seizures, and this patient has blood glucose spikes? Or this is a common dilemma we face, and we need to look at the imaging to make sense of it. Is this a pattern of diffusion restriction? Usually it's kind of more gyriform, kind of on the cortex. Maybe it goes beyond the vascular territory or atypical. That would make us think, oh, this is diffusion restriction related to seizure activity that's secondary to the seizure activity rather than the primary cause. Had a patient recently who was just mildly confused, didn't really know the date, didn't know the president, but otherwise conversant, fluent speech, telling us about going fishing the weekend before, but his family said he was a little off. We got an MRI, and there was, forget if it was flare diffusion restriction in the medial temporal lobe. It didn't look like a stroke, and we said, oh, that's a pattern that looks like seizures. Is this person seizing? We wouldn't have put the EEG on, and the patient was having 7 small seizures per hour. The only manifestation was sort of mild confusion. So the question with this type of MRI we could be, is there a stroke there or some other mass lesion that's provoking seizures, or is this a secondary phenomenon? The seizure is actually causing MRI changes. So that could be a challenging distinction in practice. We'd have to look at it. What did you and your colleagues ultimately think here, Valeria? Was the MRI, was it showing a lesion, an old stroke, or recent stroke causing all this, or was it thought to be changes secondary to seizure?
We didn't really know. I think we thought at the end this patient could have like a multitude of things going on. So we did start him on secondary prevention for stroke. But we also continued the garamazepine because we did find that he got better with it. At the same time, I mean, so for the final diagnosis of this patient, we thought, okay, he has signs suggestive of a stroke. He also could have this kind of hyperglycemic crisis that have been reported with visual hallucinations, and also the possibility of diabetic retinopathy causing Charles Bonnet syndrome. On top of all of that, you know, and at the end, with follow-up, the patient did get better with the therapy, but his diabetes was very difficult to control. So without that control, I think it was really hard to rule out any of the diagnoses that you put on the table. But yeah, this was a really challenging case, and I really I don't know. I didn't know about Charles Bonnet syndrome, so I wanted to share some teaching points about that too, if we have time.
Certainly have time. Just one quick thing. Yeah, be great to see the MRI, Valeria, if you can dig it up, just out of curiosity for this case, so we can all learn from it. In some of these cases, it really isn't clear based on the pattern of diffusion restriction if it's sort of in the PCA territory, and it's all in the PCA territory, and it's diffusion restricting, whether this patient had a stroke with secondary seizure, or whether the changes are secondary to seizure. And one way to sort that out is just to repeat the MRI in a few months and see if it looks like there's an old stroke there now, and then that answers the question, or whether the changes that were there transiently have disappeared and left normal underlying brain. Even that can be a little fraught, because if there's enough seizure activity, you can actually get some damage. But there is some ambiguity, and I agree with you. If you thought, well, this patient has vascular risk factors, as something that could have been a stroke, let's go ahead and treat for stroke. And I will say, you know, in Bishu, you brought up this phenomenon of secondary migraine. I saw a case once of a patient who felt classic migraine, kind of scintillating scotoma, flashing lights moving across. I think it was his left visual field. He was driving. Seems like most patients that have acute visual things are driving at the time. Pulled over, went to the hospital, and was found to have a new stroke. He was in maybe his 60s, and so he was not a typical age for a new migraine, so he would do an image. And the stroke was in the right visual regions. And I remember saying to the residents, there's an interesting example of the patient has migraine clinically, but it's secondary to a stroke in the occipital regions. But that's not why I'm telling you the story. Then we went to see him the next day and he was confused and he said his chest hurt a little bit and we started doing a cardiac workup. And then he had a seizure right in front of us. We realized the confusion was a postictal state from a missed seizure. So we put him on EEG, and these migrainous phenomena were occipital seizures. So this patient was having migraine aura secondary to seizure, secondary to stroke. It was like meta secondary migraine. It's like tertiary migraine or something. So migraine can be a secondary phenomenon. This, the oscillating red lights may be migrainous, the angry faces, not so much. But interesting point, Valeria, also does this patient have multiple things? They have decreased visual acuity with maybe release hallucinations. Maybe that's the faces looking not as they're supposed to, or seeing faces where there are no faces. And has episodic hyperglycemia, which can cause seizure. And so maybe there's a couple of things going on here, but probably if you really wanted a final answer, it would be repeating the MRI if possible, even repeating a CT to see if there's now encephalomalacia, which means brain softening, a sort of area of damage that looks like, oh, it looks like the patient probably had a stroke. And if you can't do that, as you said, probably wise to say, look, patient has vascular risk factors, something that like a stroke. They're having seizures, we're going to treat those. And in the meantime, we're going to do a stroke workup and put the patient on secondary prevention if we're not going to be able to decide if it was a stroke or not, so that we at least are reducing their risk of another or a first stroke, even if this was not a stroke. Wow, fascinating and complex case. Yes, Valeria, please tell us what you learned.
Okay, thank you. And yeah, I will dig up the imaging for sure to put the rest of the localization dilemma. So for Charles-Bonnet syndrome, it's characterized by complex hallucinations, as we see on this patient, usually in visually challenged people. And it is underdiagnosed in elderly patients because of the wrong assumption that it could imply a psychiatric condition or dementia and the stigma associated with those diagnoses. Hallucinations are usually not threatening, and the patient knows that they are not real, and as Aaron mentioned, are usually of small people. However, there is an infinite variety of presentations, and I encourage everyone to read Oliver Sacks' book, Hallucinations, in which he reports a lot of cases about this syndrome. Specifically, I remember the case of a lady with CVS who referred with conviction that every night she was visited by a dedicated lover. So it goes against the classic presentation of CVS. In terms of the pathophysiology, it is not clear, but the main hypothesis, as I mentioned too, is that release hallucination, meaning that after the loss of visual input, there is disinhibition of signals from the visual cortex, leading to hallucinations. And the most common etiologies are diabetic retinopathy, macular degeneration, and glaucoma. And treatment depends on the impact of the hallucinations on the person's life, because up to 60% of people refer that they have no issue with these hallucinations and are often comforting to them, like a companion. So if they're not making any problem, you cannot treat them at all, or you can give psychotherapy, but anticonvulsants, antiepileptic agents have shown limited effects. So we don't really have a lot of treatment available if they cause problems. And yeah, so that's all I got. And thank you for the amazing discussion. And yeah, that's all.
You're muted. Dr. Aaron, you're muted.
Thank you. Yeah, I had some background noise here. Thanks for telling me. And yeah, thanks to Valeria for bringing this case. It gave us lots of avenues to go down, some of which were related to this patient's diagnosis or unclear diagnosis, some of which were not. But I think all of us were challenged to think about causes of visual hallucinations from a neurologic perspective. It was interesting to hear what we all came up with, sort of the classic things, but didn't think about seizure, which is an important one to consider. Excellent. Well, excellent discussion, Umbish and Gregory, for a very challenging case. It has a lot of ambiguity at the ending. One of my mottos in neurology is embrace the ambiguity. Sometimes we don't have a diagnosis, and we have to do the best we can with the information we have, or round to the nearest diagnosis and work up for that, as Valeria did here, and treat that as well. So yeah, if you have follow-up, Valeria, we'd love to hear if you're able to find the imaging, and we can have a look, or if the patient gets repeat imaging to know what that diffusion restriction was all about. Thank you so much again, everyone. We'll try to keep doing this monthly, and I'm grateful to you for bringing cases, discussing cases, and enjoy the rest of your day/night, and see you again soon. Bye, everyone.